shift that and show our worth and show what we could be in the future. So spending a lot of time thinking about a sort of future vision. I mean, that's a bit like, here are the biggest risks. What are we doing to mitigate them? And then, but then the other and bigger, much bigger element of my 2 years so far has been this immense feeling of pride in the work that we all do and the impact that we have. So, and it's greater than, many organisations I've worked for that aspire to have impact on behalf of people and find it very hard to prove. And I think we are on that journey of showing the impact we have for people, have achieved huge amounts. So if we look at the obvious thing about dentistry, for example, dental recovery plan last week, I mean, not by any means the be all and end all or the solution, but a significant change. And almost all of the content in that was partly driven by us, and what drives us is the insight that you give us. So it's massively informed by people saying they can't get an NHS dentist for themselves or for their children, and the impact it has on them, and what the solutions might be. They can't get the information. We have been consistently feeding that through into DH and NHS England. So we were pretty happy about the plan last week. Obviously, we're asking for more. So in terms of impact on things like primary care, not just dentistry, but GP access, support for people who are on waiting lists, accessible information. I know the AIS keeps getting kicked down the road a little bit, but it is absolutely on the stocks. Amanda Pritchard assures me and is ready to be released, and they're just kind of dotting the I's and crossing the T's on that. So there's all of the really good work on kind of policy and practice change that we've all been doing over the last few years, and then responding to the integrated care system, the new structure. I think everybody's really stepped up to do that, and it has been a bit of a struggle at times because it's once again showing the worth of the Healthwatch movement and individual Healthwatch and groups of Healthwatch to these new structures, some of whom have got obviously new executives and new non-executives, and have to once again show, like almost fight for our role in it in some places. But that's been great. That's been on an upward trajectory. I think it's around about 70% of ICSs now do properly involve Healthwatch in their governance and sometimes fund them as a group. So that's been brilliant. And then, our kind of upwards journey together on profile, on the amount of coverage we're getting in the media as a movement, the amount of recognition we're getting has increased, and then the individual achievements of Local Health Watch that I see a lot when I visit, but also from the annual reports and most recently from the awards. Obviously, it's a bit of a secret who's kind of got the spots, but when I see the award entries and what pretty much all Local Health Watch do, gives me this immense sense of pride and inspiration, which massively counterbalances all the the difficulty and the risks that we're working through. So that's my kind of in 2 years, there are big risks that we have to face and mitigate, but the work we do is massively valued and massively valuable and really important. So thank you for that, and let's keep up with that effort. That's brilliant. So in terms of the policy update, I talked a little bit about dentistry. Obviously, we've had Chris McCann do the Health and Social Care Committee, which is always influential. We've influenced the recovery plan. We briefed in a lot. I know lots of you get approached from the media as well, which is brilliant to do dental stories. We've also been focusing, as you know, on pharmacy, so evaluating the rollout of Pharmacy First. Again, Will did a slot at the Health and Social Care Committee on Pharmacy First and what that might mean, and some early outputs from the research we've been doing and the work that some Healthwatch have been doing, which shows basically that people support the idea of Pharmacy First, but in the 7 common conditions, there are some they'd rather go to the doctor for, which include things like sexual health and UTIs and that kind of thing. I mean, why they didn't ask before, You know, because I remember talking to them like 8 months ago about, okay, these are the common conditions. How did you come to those? Did you ask people how comfortable they would be to talk to the pharmacist? And we're going to look into it. And I'm like, oh, we'll be really interested in your results. Anyway, so we're going to publish more on that. There's lots more in there about access to pharmacy and so on, access to medicines, which we've been talking about. Probably do a 1 year on, you know, in terms of, is it actually working? Are people using the pharmacist more? Is it reducing pressure on other aspects of primary care? We're well underway with work on cervical screening. Thank you to the Healthwatch who've been participating in that work to look at the barriers for particular communities in take-up of cervical screening. I mean, that in itself as a kind of national priority is partly inspired by some of last year's award winners in terms of the work that in Bolton particularly that we're doing on cervical screening. And Bangladeshi women. And then we're also doing work on diagnostic hubs. Are they really reducing the pressure on other areas of other providers of diagnoses? So those are some of the policy areas we're working on at the moment. We're also working on a kind of patient vision as a kind of pre-election piece. What do patients and the public and communities really want from a new government? You know, what do they want? They want confidence the NHS will be there for them and so on. So in a few weeks' time, we'll be releasing that, and hopefully that will be useful to you as well. And then in terms of the culture and values work stream, you know, I'm really delighted to hear some of the early results of the discussions you've been having. Obviously, we've committee have had some discussions, the staff at Healthwatch England have had discussions, you're having discussions all running in parallel. And I think I was hoping there would be some real synchronicity between all the different groups that make up the Healthwatch family and what we all believed in. And it turns out there is. And the same words are coming up in all of the discussions. Things like independence, things like candor, this whole kind of speaking truth to power concept, things like collaboration. So that is going really well. We will be able to fairly easily, I think, synthesize all of those discussions into, you know, some core values that then again we'll go out and talk about, okay, what are the behaviors that exemplify those values, and then how do we all hold ourselves and each other to account for those so that they're real living kind of new culture set for the whole of Healthwatch. And for me, that's really important. It's the kind of foundation for strategy work for how all of our staff feel, how our volunteers feel, how our boards feel, you know, what our presence is with our communities, with our stakeholders. So how we kind of then exemplify what that means in terms of our behaviour is incredibly important. So I'm hoping that as that work goes on, that all local Healthwatch will kind of join in with that, and that will make us also feel more coherent than we already are as a movement. So that work will carry on throughout the spring. And I think there are still a couple of workshops to come. So please, if you haven't taken part yet, do. So there's one online on the 20th of February, and there's one in London in person on the 27th of February. So if you haven't yet been involved, please do get involved, because everybody's idea is incredibly valuable in getting this new shared culture for Healthwatch. So I'm going to stop there, Gavin, and hand back to you for some further updates, but I'm happy to answer any questions people have got or any comments people have got.
Have we got any comments or questions for Louise? Doesn't seem to be any hands up. Okay, right. Well, let me move on to the next item. The next item is really building on.
Stephen's got his hand up.
Oh, right, Stephen. Right. Okay, brilliant. Stephen.
Apologies, I was late off the mark. I was wondering whether I should ask it now or not, so I'm asking. And you can park it if it can come up later or something. You've just released for consultation this year's template for the annual report. Thank you for that, for giving us early upsight of that. Just an immediate kind of reaction to it, and I know it's come through feedback, which was very helpful from our regional kind of leads against last year's annual report. So thank you again also for facilitating that. One of the challenges is for local Healthwatch that whereas we have to report and like to report things that Healthwatch England might need, it doesn't, that the template still doesn't yet allow us or give us space to report against what our local annual reporting demands are. So in other words, with 40% of our local Healthwatch Kingston income coming from additional community engagement projects, we have to then report those in our annual reporting, which we obviously we do at the same time. But it's not always easy to be able to sort of factor it into the kind of impact-led structure that you're asking us to sort of complete for a Healthwatch England annual report to government. So I think there's a bit of a push-me-pull-you scenario there, and I'm wondering whether there would be some further thought put to that. So maybe as appendices or something like that, or a bolt-on or a section where we can report additional local activity which supports local core-funded Healthwatch business. So it kind of would illustrate within that annual report then that there's that type of activity going on to make the system work for us. So it's the added value that brings and all the rest.
I'll come in on that one. I think that's an excellent idea. We certainly want to see the template as to be a template. So absolutely to see if we can incorporate that. So let's take that away and have a good look at that.
Thank you.
Thanks, Stephen. Pat.
Hi, I don't know if Louise is frozen, so I don't know if she can hear me or not.
I can hear you. I can hear you.
Oh, that's all right then. If the thing had froze. It was really good to hear that sort of snapshot, because I'm sure it is only a snapshot of the 2 years, Louise. But one of the things I know I did email Gavin that we're really struggling with at the moment is the issues around the ICBs and their funding and the reorganisation. And it's really difficult for us to be continuing with our Healthwatch work in such disarray around us. So all our trusts are in recovery programmes. Our ICB they're not allowed to do anything. We had a meeting on Monday again, and they're reorganising, and it's just how we have our impacted influence, because the infrastructure is so shaky at the moment, and it's getting more complex for us. I've been doing this for a long time, but it's just really difficult now to know where the best place and what to do, plus the fact of our resource as well. And I just wondered if you've had any feedback on that and how we can move forward in such difficult times with everything happening around us.
Yeah, totally understand. Hear that, Pat. Sorry, my internet's a bit patchy today. And I think on average across the country we're seeing it get better in terms of people, Healthwatch being included and being funded and navigating the system, but then and being included in governance. But then in some areas, as you're absolutely right, it does depend on sort of the health of the ICB and its providers. And particularly in the current context with industrial action having cost so much for all ICBs, plus unfunded pay inflation and a whole range of other factors they're dealing with, Healthwatch just sort of drops down the agenda, and listening to people drops down the agenda. So it's one of those kind of stay strong moments where it's like, you have to keep banging the drum even louder in a sense. It's kind of, well, if you're on governance committees, what are the best assurance questions still to ask? What are the in terms of the structures of the ICB as they're continuing their restructure, it's talking to them about how they're going to ensure that there'll be comprehensive engagement with local people if they're getting rid of half their engagement teams. Or there are some areas where actually Healthwatch is seeing this as a bit of an opportunity to
there could be opportunity for us as a Healthwatch, but I think the difficulty we've got at the moment is we're concerned about the brand of Healthwatch, if you like, because we're going out and gathering feedback and feeding it into whatever, it just goes into this, nowhere, if you like. And the trouble is they've all got their job evaluation. We're losing 4 out of 10 staff. A lot of staff I've had a lot of relationships with are all going. And we've got a good relationship with them. And I do feel for them, because when they come to us, they know it's an issue, but it's just how can we keep that Healthwatch brand alive and the value of the Healthwatch, because it's no good telling us if we can't do anything with it. Yeah. So, and that's just where I feel at the moment. It just feels a bit disconnected.
It's a difficult time for sure. I think when all the restructures are over, so at the beginning of the next financial year, it should settle down a bit, I guess, in the ICBs themselves. And then it's kind of, the other thing is that I'm always really happy if I can do anything to help. And obviously Gavin and the team, I'm always really happy to, if you to write to ICB chairs and chief execs and say, look, can we have a meeting with the local health watch, because it's improving, that relationship in most of the country, and I'm a bit worried that you're kind of lagging behind a bit, or finding better words than that. Do you know what I mean? There's sort of, if there's anything
I think
I can do.
our relationship's really strong, and that's one thing that's getting us through this. I think what we're concerned about, so I could go out and do a piece of work and get some insight, but so what? Because how do I get that influence? Because they're not in a position to change, and like I said, everybody's in a recovery program at the moment, and it's just getting more complex for us to be able to navigate around where you don't know who's going to be in a job tomorrow, and they're starting something.
Totally.
We had a really good one when they came and asked us to take the lead with the LCP and the engagement, which was great recognition for the South, but there's no money, and they want me to supply all the meetings, pay for all of that, because they haven't got the money to do it, and it beggars a bit to leave. So I've gone back with that challenge. We want to help and we want to do it, but there's a limit to what we can do as well. And it's just trying to strike a balance. But I just wanted to put it on the radar that there is some concerns for me, at the moment around all of that.
Yeah, frustrating. Yeah, totally understand. I think Gordon had his hand up there.
Hello, everyone. Hello. Yes, listening to these discussions seems sort of familiar in some ways. I mean, we're luckier in South West London in that we've got the setup for the ICB and with our executive leader who's here today, actually. But the challenge for me is something of the sort of strategic element between, obviously we want to work with the ICB and influence what they're doing. However, there is a risk that we end up only focusing on items that are on the ICB's agenda, when we're also supposed to be raising awareness of things that the ICB probably don't know about. And to me, I just wondered about that strategic tension and how much time we should be putting to things that, we should be working with the ICB and working on things. And to pick up your idea that Pat said about needing to, we try and find projects where we know before we start the project where's this going to land, who's this going to influence. We do that as a part of our scoping at the beginning. But there are times where you hear about things which you think this is worth exploring, but there might not be a place for it to go. There's a risk because we're trying to influence, and it's very important that we're trying to influence and show our impact, that we end up being drawn into the sort of agendas of the ICB at the expense of doing what we're supposed to be doing, is ultimately hearing things that are happening locally. And I just wondered how other leaders are managing that challenge. Is there a certain, are you agreeing with your boards that a percentage of it should be about stuff that comes from grassroots up, and the others should be ICB facing? I'm just interested as we're getting into that sort of business planning part of the year.
Yeah, couldn't agree more. And I can see other people want to come in, but I sometimes say, it's kind of, we need to say what matters to people rather than what matters to the ICB. And I think it's probably worth writing to the chief exec and saying, this is what matters most to local people. It might not, or just challenging them to say, do you know what matters most to local people? And is that reflected in your board assurance framework and your committee agendas and your board agendas? Because if I think of where I am in Sussex, what matters most to local people is access to NHS dentistry, mental health provision for young people and the whole neurodiversity pathway, access to GPs and a range of issues. Yeah, what gets talked about are all the performance stats, ambulance conveyance times, A&E waits, 62-week for cancer. So those are the things, there is a real mismatch there. And I think there is around the country. So it's worth putting that challenge into the board. Do you know what matters most to local people? Can they actually articulate that? And, wait to see what they say, because some of them won't actually, the good ones, I think, are able to acknowledge that. And then once they've answered it, say, and how is that reflected in your board discussions and your assurance and your board assurance framework and your committee agendas? So yeah, I 100% agree with that, Gordon.
Okay, I think there's no more hands up, so shall we move on? And that's really building on quite a lot of the comments, actually, because what we've done at Healthwatch England, you all provide us with some through our annual survey feedback on the strength of relationships that you have with your ICSs, and we also collect other information on your funding situation. But also what we've done as well for 2 years or so now is look through all your annual reports and look at the kind of impact that we're picking up from Healthwatch. So I thought I'd just give you a sort of reflection back on what we've seen, just to share that with you, and some of the things that we're going to be doing as well. So I've got one slide that's just probably a useful thing for me to focus on. So I'll just share it. So it's an aid memoir for me, really. So I think it just let me just make it full screen. Yeah, on the just on that question of the annual reports and demonstrating impact, I think one of the things that we hear from commissioners, from local authority commissioners, very supportive of Healthwatch, but they absolutely want to know what impact that Healthwatch are having. And I think I've been around now for over 5 years now, I think. So it's been really fantastic to see the real shift that we've seen in Healthwatch demonstrating their impact. And I think we're just looking through all the annual reports, we've seen a huge increase in Healthwatch being able to show that in that the difference that you make, that Louise was referring to, and that obviously the national awards is going to be an occasion to celebrate. So if anything, I still think there's a lot of underreporting of the difference that Healthwatch make. So that's certainly something that when we've come to have discussions with individual Healthwatch about our reflections, so often we're missing that understanding of the difference that you're making. So I think there's even more that we can be doing around communicating that. So there's absolutely fantastic examples. So we really want to, we've absolutely made sure that the annual report template is really focusing on the impacts that I'll take Stephen's points on board, and we can look at that. So what we want to do this year as well is, if you can, is to share the kinds of messaging you want to include in your annual report ahead of actually the publication. What we've been doing in previous years is almost after the job's done, is then engaging with individual Healthwatch. But we'd really like to understand that ahead of that. The other thing that's been fantastic as well is we are now able to see all the fantastic examples of the difference that you make. And something that we're going to introduce now is just the examples of when we use your work or use the feedback. So when we come on to data sharing, I think giving back the message that we actually directly use the work that you are actually doing and the reports, etc. So Louise mentioned the patient perspective. We've got all the examples of where we've quoted Healthwatch's work in that, and we're going to feed that back to you so that you've got a real sense of when we're using your individual work around that, because we think it's really important. And then I think Will's going to be coming round, Will Pett, who's Director of Head of Policy, and specifically he'll talk about the different policy areas that we're going to be working on. But again, we want to hear examples of when that policy change at national level is leading to change at local level, and get that real feedback loop around that. So there's lots to be done around this. So, but it's really great to see a real positive step change in being able to demonstrate impact. We've also seen, you also told us about income generation, and we're seeing an increasing number of Healthwatch, not right across the board. So I know there's a huge variety of views on generating income versus, taking away from your core activities. But there's substantial amounts of income that are now getting generated by individual Healthwatch. So overall, we've seen that amount increase from 3.5 million to up to 5 million. Now, quite a lot of that is to do with the ICBs, and the support, which I'll come on to. But it's not just that, it is other support. And I think, Stephen, you mentioned commissioned activity. So it is that Healthwatch are being able to generate income around that. But that doesn't get away from the horrible fact, I think, as Louise was saying, around the core funding situation. And we've seen basically an overall static position. We'll be producing a report on the Healthwatch funding situation, as we do every year. But I think overall, as a static, which means a real cut in funding for Healthwatch. And again, it's the disproportionate impact on individual Healthwatch. So it's not that's not the situation right across. I think when I looked at it, I think only about 10 or perhaps 10 to 15 Healthwatch got an inflationary increase in line with what it should be, and the rest either had a cut in their funding or static position. So that really underscores why we're doing so much work on looking at the sustainability of the Healthwatch and the Healthwatch model itself. On more positive news, Louise mentioned again on the work with ICBs, and I think you're telling us that given the permissive nature of the legislation, that you've managed to develop really effective relationships. You're reporting that you've got really effective relationships with your ICSs, and I must say that when we've had engagement with ICS engagement leads, they're also reflecting that back. So they see a very positive relationship with their Healthwatch and the value of that Healthwatch. And again, we've been tracking the representation of Healthwatch on ICBs, and 67% of Healthwatch told us that you had representation on the board, and 84% on the Integrated Care Partnership board. So strong representation right across the country on that one. And again, with Healthwatch have been doing a lot to try and generate income from the Integrated Care Board, particularly where Healthwatch are having to collaborate together and coordinate and sort out representation, etc. And again, we've seen the income go up. I think it's about 1.5 million now that the ICBs are putting in. So huge amounts still to go. And again, a strong message around the variation. And Pat, I think what we're going to be doing is certainly putting a lot of communication to ICBs about just how across the country they're supporting health, how ICBs are working effectively with Healthwatch, and really trying to stress the sort of variation across the country, that and give them examples of how that's working positively. So we're going to be doing that with the NHS England, who are also been supporting the action learning sets that 7 or 8 Healthwatch actually undertook. Just on one of the challenges, I suppose, just to reflect back, is a sort of standards kind of thing, and it's really been difficult for us to measure overall activity. So I suppose it's not. I don't think there's much we can do about that. But that is, the fundamentals about number of people that Healthwatch actually engage with, and number of people that that you provide information and signposting to. So it's just. I suppose it speaks to Stephen's point that you've got contractual obligations and monitoring requirements, and I think there's a difficult way for us to get a consistent view of what that activity looks like. And then the other thing that you told us about was all the priorities that you're going to be working on, and we're hoping to use that much more to support any collaboration between Healthwatch, and we've been running a number of activities where we're spotting Healthwatch would like to work together on a particular issue, and an example of that was around Healthwatch wanting to work around young people. But it's again a trajectory is around sort of tackling inequalities. We're really seeing a really strong emphasis on Healthwatch doing that. And I think that's a trend that's been growing over the years. So that's a particular focus around that. And then last but not least, something that really important for us is we've done a huge program of work to put in place infrastructure around data sharing. A really fantastic response from the network. So a massive thank you from me. I was the one that was often bringing the bad news about the change, but I think, you know, just to give you a sense of what the change is actually, back in 2019, we had about 50 Healthwatch which were sharing data, and that was because of our systems simply couldn't cope with, you know, the different varieties of ways that you collected and stored your data. So we changed the infrastructure around that, and I can tell you now that we've got about 117 Healthwatch which are now sharing data, so only about 30 to 40 to go to all Healthwatch doing that. So just, you know, we've had a 400% increase in data sharing in January, so it's absolutely fantastic, and it's so important to our research team. You know, again, going back to that patient perspective piece of work, that is, you know, essentially reliant on the data that you're sharing with us. And then finally, on the demographic data that Healthwatch collect, that I suppose is variable. So again, we asked about your confidence in collecting that, and there seems to be a bit of a mismatch, and we need to understand what this is. The mismatch between confidence in collecting, and you may be collecting it, but we're not necessarily getting that at Healthwatch England. So we've probably got to do some work to really understand what that is and what we can do to support you to share that. Because again, that's so important for us to understand who we're reaching and to inform our analysis, and including around sort of the inequality angle. So that's a bit of a snapshot on just the kind of things that we've been hearing at Healthwatch England. I don't know if anybody's got any questions before I move on. Lucy has, right. Lucy, did you have your hand up? No?
Nope, sorry, not
No,
me.
right, so no, okay, no hands up, right, brilliant. Okay, the next item that
Owen,
sorry, Gavin.
Owen, right, yep, sorry. Owen.
Sorry, just going
to
to talk, just raise one thing around sort of data sharing and stuff. I think you at Healthwatch England are doing a lot more sort of paid advertising and stuff on Facebook, which is obviously generating a lot more profile for you. There's something about how do we add in that message about don't forget you've got a local Healthwatch, because what that then seems to be doing is it's generating a lot of feedback back to you centrally, which obviously you're adding into your thematic analysis. We then get back anonymized bits of feedback because obviously there are GDPR issues. So we can't follow up some of that stuff. And I just wonder whether, I think Sue Edwards is doing some work around that, but just as a short fix, can you just not get some consent thing on your feedback form that says if you submit this information to Healthwatch England, we will share it with your local Healthwatch? Because I know we've talked about it, the group of Healthwatch and our hosts, you know, that we get quite often there's feedback where we would like to respond to the individual, but we can't do that.
Yeah.
And it's just, is there something that we could do? It's just some quick fix around that.
Yeah, so I think it's good timing that, because we're actually looking at that, the what we call, I think we call it a feedback form or whatever it is, and I think there's two things. We're looking at how we get that so that we can share that, get the consent for that, but equally how you can access the data, so that we've got some GDPR issues at the moment, which is not brilliant, I must say, in practice terms, which we're going to address. So at the moment, you don't have access to the National Data Store, but we're going to be giving you access to your data that's actually stored on the National Data Store. And that should give us then the ability to match up anonymous data, which we must do because we'll be collecting sensitive information, but we can also collect separately personal data, and we can match the two up so you can actually then contact the individuals. So hopefully, and this is the bit that I really want to understand, is once we do some change, I do want to really understand the feedback from Healthwatch. You know, is it working? Is it actually right for you? So please do come back, Owen, when we introduce that, probably in the next couple of months. And does it actually improve things for you? So please do come back.
Thanks.
And Sam.
It was going to be on a similar vein, actually, around the data sharing, is that it's a bit of a two-way street. So it would be really great. I think you touched on it, Gavin, in terms of getting more feedback about how our feedback and insight is used. That's, I think, really, really important, because it is much easier, but it's still quite a lot of work for us to reformat our insight and things like that to share, and we do our best to do it and on time and things like that, but it's still an added resource for us to be able to share it back with Healthwatch England. So any feedback on how that's used is greatly appreciated, but also on that feedback form, and I've noted Sue's request for Healthwatch to get involved in redesigning that, but also just, you know, the information that Healthwatch England are collecting is not always the most helpful for us. So when we get through some of the website forms, and regardless of, you know, following up with that individual, when it just says, where do you live in Surrey, and I've had access to GP practice, that's really difficult for us to use then, because we've got 140 GP practices. We can't even narrow it down to what part of Surrey or something, you know. So it's trying to make that as useful for us as possible would also be helpful, I think, from that point of view. And I don't know if that's directing people to share with their local Healthwatch, or adapting, you know, the Healthwatch England forms and things like that as well. But I think there's probably some work to be done in what we collect as demographic, and what you guys collect is slightly different.
Right. So I think at the moment, I think there'd be the ability to follow up on individual. So if people do share and you're interested in the feedback, then there's be an opportunity to follow up. Would that be sufficient, or would you need more than that kind of thing?
Well, I guess it depends, doesn't it, in terms of what people are sharing as their feed, you know, if they want to be followed up on or not, or whether, you know, it can be a kind of case of getting a little bit more information. But even like the name of the service, rather than what type, you know, we quite often get things through where it just says like GP surgery, and even hospital, you know, we've got, what does that mean? We've got 5 acutes anyway, let alone thinking about community hospitals and things like that. So it makes it really limited as to what we can do. And actually, it's a really powerful message for us to say, people are proactively contacting Healthwatch England about these issues. This is the, you know, how important it is to people. But it's just difficult for us to use it at a local level when it's very top line what we get through.
Right, that's really, really helpful. I think, again, we'll do it as a pilot phase, and when we bring in the change. So I think it's as much about the mechanics, but it's also about the communication we have to the individuals about what information is going to be useful. So please do keep that feedback coming. So we'll, as I say, we'll come up with a solution, but we want to make sure that we can do as much as possible to make it work for local Healthwatch. Gordon.
Yeah, I'm aware from this information that we're still yet to fix up our meeting with Sue to discuss how we're going to sort of data share. We must be one of the 40 that haven't yet shared. We are internally trying to work out how we you know, align our data, because we've got obviously we've got our own database, and we're trying to align it to fit with particularly the demographic information that the Healthwatch provide. But it just occurred to me, and it's all this GDPR kind of data sharing. When we take a survey, we're trying to work a way that if we take a survey, we then draw that into our database and we can send it to you. Do we need to put a consent in that our information will also be shared with Healthwatch England? I just wanted to get that clarification right. I mean, logically, it makes sense to me, but do we have to specify? Is it good practice to specify that we will share that with Healthwatch England?
Yes, I think in your privacy notice, we've given a template one for that, so that we've set out some wording on that. You're absolutely able to do that because of public task. It's absolutely one of your statutory functions that you have to share the data. So it's just a case of getting the wording right, but absolutely. So it's a simple fix, really, as long as you get the wording right from the start. It's harder to do it once you've, and you don't need to rely on consent, you rely on public task.
Okay, it would be great if you could send that along. Just want to check whether it may be that our current privacy notice actually does say that, and we've already covered it, but I want to make sure we do.
Yeah.
Okay, brilliant. Thank you.
Okay, I'm just conscious of time, so I think without further ado, I'll just mention the escalation process that we've been working on. As Louise said, we've been having a real sort of deep dive on the experiences of Healthwatch around patient safety. So we pulled together a couple of webinars now where Healthwatch have shared their experiences around particularly where there's been quite a tension on patient safety. So we heard from Healthwatch Shropshire, Healthwatch Nottingham, where there's been the Ockenden inquiry regarding maternity services, for instance. And arising from that was a suggestion, I think it actually came from Joy Bashan in Healthwatch Greenwich, but around is there a sort of more formal way for Healthwatch to actually raise these kinds of issues, particularly with the CQC, and including at particularly in their regional CQC meetings teams, sorry. And then if they're still finding that route difficult, then an escalation through to Healthwatch England and national CQC, and potentially with other patient safety organisations as well. So we've gone away and looked at this and come up with a proposal around sort of, I think it's I'll be sending around the drafting, but basically it's the process would be obviously raising that yourselves with the body concerned, and then raising it with CQC. And then if you're still unhappy with that situation and the decision of your board, then you could raise that formally with Healthwatch England and nationally the CQC. Now, we discussed this actually just only yesterday with CQC, and there is a way with their new regulatory platform where they're going to be able to record every instance where a Healthwatch has raised that with the CQC. We're going to produce a pro forma for you to actually send that through to the CQC, and that would trigger that being logged on their regulatory platform. We would then get a report on a regular basis about how many Healthwatch are actually raising such matters and the status of that and what action has arisen from having raised that issue. And that will give us an oversight of the number of instances that are getting raised and the status of that. And also we can make sure that that's getting acted upon. But equally at national level, because we regularly meet with CQC, any issues that are feeling blocked, that we can actually seek to address those with both CQC, but also we would be considering any other patient safety organisations that we may want to raise the issues with. This particularly arose because Healthwatch felt they were raising cultural issues with their relevant body, and they were getting a sort of, they felt they weren't getting listened to or getting acted upon. So that was what prompted this. So I see a number of hands up. I'm conscious of time, so let's make sure we hear from you all. So Sarah.
Yeah, hi, thanks for that. Obviously I'm from Nottingham and Nottinghamshire, and obviously we've had these particular issues. I'm really happy that there's been movement on this, and this pro forma sounds really helpful. Have you looked into how we work better with scrutiny, health scrutiny? Because one of the things that we've done here is built a relationship with one of our health scrutiny. We've got 2 areas that we cover where we know we've got within our powers, so to speak, we can escalate to health scrutiny and use health scrutiny as a way to raise issues and have them looked at. But I think it's something that they don't understand. So we get invited to scrutiny meetings, which is great, but I don't think they understand that there's a sort of element in which we can escalate to them and be able to get them to look into things with us as part of this process. Did you come across any of that?
I didn't. I don't think that was mentioned. Louise, you were on the call as well. I don't remember that issue, but I think it goes back to the fact that what they did say was the ICBs didn't seem to understand the role. There was a definite message around understanding the role of Healthwatch. I don't know, Louise, if you want to come in on.
I think it's because this is specifically about patient safety, which is a little bit out of the remit of HOSCs. I mean, I think the issue of HOSCs is a whole different question that we need to look into about, you know, what's Healthwatch's role on HOSCs and health and wellbeing boards and HASCs, you know, and what their relationship is with seeking assurance on, you know, the provision of health and people's experience across local authorities. So I think that's a work stream that we need to give some thought to, Gavin. But because this is really specifically about, have you got safety concerns about a trust or another healthcare provider? And Gavin is doing great work with trying to get the CQC to get this on the regulatory platform, but it's still a bit of a grindingly difficult job because there isn't space on the reg platform in its current development for individual kind of qualitative experience entries. It still is just a tick box of, has the Local Healthwatch raised something about safety about a particular provider with the CQC team. So I know that the reg platform CQC, if you know about kind of large scale IT development, they've got a list of as long as your arm of development asks, and Gavin is pushing as high on that list, but they've got like 100 other things that they need to do to the platform. We are also trying to get an interim solution with the whole talking to, you know, the obligation for the CQC regional teams to just talk to you more and more frequently, and for that to be an assigned number of days for the CQC teams. So we're also trying to negotiate that with the relevant bit of the CQC, so it actually forms a part of the SLA of the regional CQC teams to talk to groups of Local Healthwatch. But again, that's a little bit of an uphill struggle, and often, as you said, Pat, early on, depends on relationships.
I think a strong message is as the new teams get put in place, and I know there's been a lot of you know, changes, etc., as that transformation program's been put in place. We do want to hear from you if there's any issues at all around your relationship with CQC. So we meet on a regular basis with CQC nationally, and we want to do sort of, you know, both sides of the equation to really support effective working between Healthwatch and CQC. CQC will also be doing an evaluation of the relationship between CQC and Healthwatch, so there'll be an opportunity for you to comment on the status of your relationship, and we'll want to track that. So previously we've done that, and you've reported to that, but we wanted them to really own this, so we're going to be monitoring that with them on that. So it's an opportunity for you to comment on that. Sam.
I think this is a really big step forward, and I think this will be really good. So thank you for all of your work with it. I was wondering whether there is a kind of mutually agreed definition of what an escalation is, because I think it can be tricky. I think, you know, our CQC teams have kind of been saying, tell us everything. Anytime something comes through, but, you know, tell us it. So we're doing a lot of, you know, escalations to them. But internally, you know, between us, we've kind of got an informal definition. But I wonder, especially seeing the things that are coming through around PSERF and things like that, you know, we wouldn't have the kind of level of detail that would lead to something going through PSERF, for instance. And it's more of a, you know, those cultural bits and things that are slightly less tangible to be able to put forward. And I know internally we've struggled with the definition. So if there was any kind of guidance or steering, that would be helpful, I think, to have, just so that we're broadly doing the same sorts of things.
Yeah, so I think what's going to be good is this: if we pilot this, I think, and we really try and understand what actually will be helpful on this, because I think coming up with a form of words is quite difficult. So to try and pin it down, but equally, because what we don't want is to stop Healthwatch being able to because I think we even struggle on the word like evidence, because you might not have hard evidence on this. It may be soft intel that you're actually getting. But equally, CQC then say, oh, we are not, you know, our regulatory functions as well. It's a bit beyond me in terms of being able to work that out, but that's the kind of thing that we'll need to get right. I see, Louise, you just come off mute. So
I was just wondering on that, because it's an excellent point, if we could commission a group of Healthwatch to come up with that definition, because it's who would face those kinds of issues. Because I was just thinking, what could it be? You know, like 3 times you know, you've raised an issue and you've not had a response or something like that, or you've not been allowed into a particular setting or something. So there's, you know, some kind of measures without it being over-engineered would be great for us to commission Healthwatch. Gavin, if you agree.
Sounds like a good move. Yeah, absolutely. Yep. Okay, we've got Pat.
Yeah, thanks, Louise, for that about the relationship, because I think, you know, it's gone really poor, I think, you know, from my experience over the years, and it's just the fact that they're reorganising and they're not in a position. We did have a meeting with somebody who's meant to be a relationship person for Healthwatch, but didn't really understand the role of Healthwatch, which I thought was quite interesting. They do deposit information to us, and then when I ask for clarity, I've got to go back and chase them about half a dozen times, and it was to do with, we know that the ICBs are going to be nationally audited, if you like, but I was trying to find out about adult social care, how that was going to work, but there seems to be lack of information and cooperation, for want of a better word. And then we get a random email that somebody wants to meet us in another area, which we are saying, well, we're already trying to bring it all together, so it seems very uncoordinated. Just going down to the escalation, what we're finding, I think, because of the everybody so under pressure, it's about the threshold. So we get kickbacks from safeguarding as well, that it doesn't meet their threshold because they're not in immediate danger. We had one with a care home that was really bad, and people took photographs, and we had to go through sort of a mire just to get it into the right place for somebody to respond to. I've just called a meeting with our ICB complaints team, because again, we're getting a lot of not so much vexes, but people are just exasperated that they've been up and down the system and they can't get the answer they want. And I think what we're finding is we're trying to make sure we're making the right decision where we bail out, because if there is something there and they come back and say, well, we told Healthwatch about this happening in the trust or whatever, and that's a big sort of risk for us that we've identified, but they're getting really quite hard things to sort of crack through. So I've called a meeting with the PALs and that, and trying to say, can we work together a bit more closely on this, so we're not sending each other around in the same pot, but actually if the answer's no, sorry, we can't do anything. And it's just how we bring all of that together, really. It's quite, and it's getting more exasperating for us because we're not quite sure where to put them and signpost, and they come back to us because they can't get the help they need. So the CQC really have got a little bit more role, I think, to help to work with us on some of this.
Right, that's yeah, that's really helpful, Pat. I think that's the kind of thing we can certainly feed into when we've had discussions with CQC on that. I'm conscious of time, and I know people have got to go. So, shall we just take this? I think there's a couple of Sarah. You've had your hand up for a while, I think. Oh no, it's an old hand, right? Gordon, is that an old hand or a?
No, new point.
New point. Yep.
New point. So yes, scrutiny. Well, I have quite a good relationship with our scrutiny, and we regularly share our own sort of data and reports, and also sort of advise them, you know, giving a sort of outsider's perspective. That said, we never have to raise a serious issue. It's more generally our reporting. But I'm trying to understand. I think they're always trying to find their feet. The same to a certain extent with the Health and Wellbeing Board, but certainly with the scrutiny. And I think the challenge is that every year, of course, it's in constant flux every year. They might have new members, some go, so you don't get that continuous relationship. So I think it would be good to get some advice. I mean, as I say, they hold us in good regard and us them, but I wonder if there's a better work, if there's some advice that Healthwatch England can give on how we should be working better with HOSC. That would be useful. I'm also interested in knowing a little bit more about how the sort of ICB related HOSC. So there's a Southwest London HOSC as well. How that relates, how stuff can be placed up there and concerns can go up that way, to hold, because presumably the Southwest London HOSC can hold the ICB to account. And it would, I think there's a whole area here about how we could do a bit, you know, we know there's snippets. I mean, we want to raise issues of dentistry with the HOSC, but you have to work through the individual place-based HOSCs who have to sort of raise these issues up. So to me, that is something that I'd like to see I just want a bit more guidance that we're making the best of the relationship, really. I mean, what a really good example is of something which we've wrestled with in South West London is there's been a bit large consultation on the changing of paediatric cancer services, and we're not, as Health Watch, pretty convinced that the consultation, probably done to the letter of the law, but done in a way that has already decided what they want to do. And although there's been quite a lot of feedback, it feels that we've been, and we've wrestled with it, I think, both as a region, but also as individual place, on how much we promote it, how much we believe that actually the consultation is truly engaging with people. And even that has come across HOSC, and I have to sort of discussed it with them, but where does the power lie? Because this obviously, this consultation is being led by NHS England, but I use that as an example. I'm not convinced that maybe we're doing the things as effectively as we could, but I, at this moment, can't think of a better way of doing things. And I think if we had some assurance, that would be helpful. On the CQC, I would say that, yes, there does need to be a better relationship. I occasionally get emails saying, we're going to go and visit these services. Do you have any information? And usually with a six-week window, which isn't bad, but, you know, had we known in advance, we could probably go out and proactively do some more stuff. And I've always found the relationship with CQC, I've never, again, been completely sure of what we're supposed to be reporting or the best way of reporting. So I hope that's useful. A bit more guidance on how we work with the CQC, and guidance rather than having events. I know the CQC like to do these sort of Health Watch and CQC events, which I come out, be honest, more confused than when I went in. What I want is guidance notes. Notes. Things that I'm expected to do and ways of doing. And yes, if there's pro forma forms, that would make it easier. Thank you.
Right. Okay. Well, thanks so much, Gordon. I think let's end on that. I'll take that back to CQC, and we can certainly develop some guidance around that. We are planning to do that anyway, so it's a good reminder that we're going to be doing that in I think it's March, April time, so something around then. Okay, I'm conscious of time, so huge thank you, Louise. I don't know if you want just to say wrap up and then we'll go, but yeah.
Oh, no, brilliant meeting. I think Kathy put in the chat, could there be 1.5 hours? Because I definitely think there's an appetite for. I think every point that people have raised has been absolutely brilliant. There's a lot we can do with all of that, and people learning from each other as well. So thank you, everybody. Really good to see you.
1.5 hours. Can you? Right. Okay, we'll get it in the diary. Okay, brilliant. Okay, thanks everyone. Thank you so much. Good to see you all.
Bye.
Thanks.